Hello everybody, I'm Dr. John Oldham, Chief of Staff at the Menninger Clinic. Welcome back to Menninger Mindscape. Today I want to tell you a little bit about just one little tiny piece of the American Psychiatric Association annual meeting, which was held in San Francisco last week. It was a huge meeting, had about 16,000 people attending, so we would need, I think, a week or so to go through everything that happened at the meeting. I was doing a number of things and was a discussant on one symposium, and I just thought maybe it'd be best to focus on that because I think you might find it interesting. And this was a symposium entitled Divergent International Guidelines for the Pharmacological Treatment of Borderline Personality Disorder. And you know, personality disorders is an area that I've been particularly interested in my career. And I was fortunate earlier to chair the work group for the American Psychiatric Association that developed an evidence-based practice guideline for borderline for the APA. This was published in the American Journal of Psychiatry, but quite a while ago, over 10 years. It was published in 2001. We updated it a bit with a guideline watch in 2005, but it's still now not as current as it needs to be. I'm currently on the steering committee for practice guidelines of the APA, and we're planning to do an update of this guideline, but it's not yet been launched. But what you may not know is that there have been practice guidelines developed for treating patients with borderline personality disorder in other countries, and this particular symposium was put together jointly by Theo Ingenhoven, who's from the Netherlands, and Ken Silk from this country, who's at the University of Michigan. And what we did was had an opportunity to learn about the practice guidelines that have been developed in other countries. Ingenhoven was involved in the development of a set of practice guidelines in the Netherlands, and those were published in 2008. It was followed by a separate set of practice guidelines for borderline patients in Germany, and that was published in 2009. Then in that same year, there was the publication of a practice guideline for borderline in the United Kingdom, in England, as a set of guidelines that's part of what's called the National Institute for Clinical Excellence, or the NICE guidelines. And then more recently, there has been a set of practice guidelines for treating patients with borderline personality disorder in Australia. So we had representatives from all of those countries joining this symposium and talking about the different guidelines. I would start out to just make 2 points and then just summarize a few additional points with regard to these discussions. First of all, in this country, there is no FDA-approved indication for the treatment of borderlines with medication. There is no medication that is labeled as a product label indication for the treatment of borderline personality disorder. So when we think about what medications may be helpful as part of the research literature and what the published studies show, this guides us in terms of clinical practice, but it's not yet at a point where there has been a medication that has been specific for this disorder. So it would involve what's called off-label prescribing, and that's something that's very commonly done as part of medicine, and it's something that needs to be done thoughtfully and in an evidence-based, guided way. One interesting thing that came out of this symposium was that even though these are practice guidelines that have been developed in different parts of the world, all of them agreed. And what they all agreed on was that the primary or core evidence-based treatment for patients with BPD is psychotherapy. That was what we concluded in our APA practice guideline, and these additional guidelines have all concluded the same thing. So that's important as a starting place to understand that the primary or core treatment is psychotherapy. Medication can be helpful, and all of these guidelines generally agree, with one possible exception, and I'll say a word about that in a minute. that there may be some added benefit if you think about using medications in a symptom-targeted, adjunctive way. So the treatment is psychotherapy. Symptoms that emerge, such as a lot of anxiety or anger or irritability or depression or mood instability, may be helped with additional treatment with some medications. Usually it's recommended to be fairly low dose and usually time limited. One of the risks that you have to be very careful about, and all of the guidelines make this point, is that there is a risk of what's called polypharmacy with these patients, because these patients will be given medications and often one will be added to another and a third added on top of that. And they will be given them sometimes by a family practice doctor or a primary care doctor or their treating psychiatrist, but they don't get sequentially evaluated, but rather added on, and that sometimes creates secondary problems that usually are not helpful. So that's something one always has to be careful about. In our practice guideline in the APA, we developed a set of algorithms, which are sort of stepwise plans for how to try and help with medication when you do have symptoms that are appropriate targets for medication treatment. But we said in the text that these were based on not a lot of data at the time, because there had not been a great deal of research done at that time. First-generation antipsychotics, for example, were mostly the studies that were done, and very little had been done with mood stabilizers or with second-generation antipsychotics. So the nice thing about these presentations at the symposium was that it brought us new information, which tilts us in a little bit different direction in terms of what the general conclusions are as the best approaches to managing these symptoms in these patients. To some degree mirrors what is in Section 3 of the DSM-5, which is the alternative model for personality disorders that is based on inherent personality pathological traits. So if you look in that section, you'll see a new way of thinking about borderline personality disorder as primarily an impairment in a sense of functioning, in a sense of self and interpersonal relationships, combined with the presence of some pathological personality traits in the areas of negative affectivity, disinhibition or impulsivity, and antagonism. And those are the kinds of traits that can be reflected in symptoms that could be approached with some benefit with medications. The new data from the studies that have been done generally demonstrate that mood stabilizers are more likely to be beneficial for symptoms like anger and impulsivity. That may also be true for some second-generation antipsychotics, and those will also be helpful for cognitive and perceptual differences or symptoms that can be, in some cases, pretty prominent. It's interesting that one of the studies showed that a first-generation antipsychotic was equally helpful in handling these kinds of targeted symptoms, such as anger and impulsivity. And that reminds me of the Katie studies, which demonstrated that the first-generation antipsychotic generally could be very beneficial for treatment of patients with schizophrenia, not just the newer medications. In our algorithm in the APA guideline, we focused with the antidepressant class of medications called SSRIs, selective serotonin reuptake inhibitors, as a starting place for many symptoms, and particularly included depression symptoms, but also impulsivity. But the data are much stronger now that it would be a better place to start if you'd start with mood stabilizers or an antipsychotic in dealing with some of these anger, impulse, discontrol kinds of symptoms. If there's a lot of anxiety, however, particularly the German guideline recommends that you might be finding some benefit from SSRIs, and certainly with depression. It's important to add that many times patients with borderline personality disorder have co-occurring other conditions. So they may have major depressive disorder in addition to the personality disorder. And if that's the case, you certainly want to treat the depression according to the evidence-based guidelines recommending treatment for depression. There was one indication that one of the second-generation antipsychotics, olanzapine, may not be indicated and could even be contraindicated, with some indication that it increases suicide risk. So that's an interesting thing to consider. The British guidelines came to a pretty strong conclusion, and they concluded that you should treat with psychotherapy, and there was not evidence that supported the use of medications, and they recommended that medications not be used. I personally don't agree with that conclusion. I think of the motto that we hear fairly often, which is absence of evidence is not evidence of absence. What that means is that if there aren't any good data, the conclusion is don't do it in these guidelines. I don't think that's the appropriate conclusion. I think the conclusion is we don't know. And if we don't know, then we need to go do some more research and learn some more. So I think that it's better just to say that if you aren't persuaded by the quality of the research, if you think the numbers are too small or the conclusions are not strong enough, then the argument is we need to learn more. But you still have to be the doctor in the room making the best decision you can. And when you do that, I think you may find that it's beneficial to use some of these medications. The Australian guideline that's brand new really was built on some of the earlier guidelines, borrowing from the frameworks established by them. And really their overall motto and sort of principle was harm minimization in the use of medications. And I think that's an important principle that we should all think about. I have that particular guideline in the downloaded version here, and it's just showing it to you in my hands. It's in the public domain. It's perfectly available, so if you just Google it, and it's the Australian Government National Health and Medical Research Council Clinical Practice Guideline for the Management of Borderline Personality Disorder. You'll find a lot of really good information in there, and I mentioned this one particularly because it is available publicly. It doesn't cost anything, and it's published in 2013, so this is brand new. So that's a quick, once over lightly summary of a very interesting set of discussions from around the world. The other thing that's implied here that is obvious, but just to make a final point of, patients suffer with borderline personality disorder, not just in this country, but all over the world, and this is recognized as a seriously stressful, disabling condition. But it's also recognized as a condition that we now know can benefit, and patients can get much, much better with treatment and over time. And it's really a good news story at this point. But we have to be careful not to overuse medications and know how to do it using the best judgment we can. So thank you for joining us, and look forward to talking to you again next time.